So for the rest of the afternoon, our presentations will be more quick hits on the various forms of COVID research that have been done on campus and the media response to those. Our first speaker for that portion of the program today is Michelle Barron. Dr. Barron is the Senior Director of Infection Prevention and Control at UC Health and a Professor of Medicine in the Division of Infectious Disease here at the University of Colorado School of Medicine. Her talk this morning is COVID-19, Hindsight is 2020. Dr. Barron.
Thank you very much for the opportunity today to speak. I am going to talk about three major things, and once my slides are up, we'll go over it really quickly, and I think I can control them. Yep. Oh. Can advance.
I think we're not advancing, David.
Nope. Try this again. All right, great. So we're going to talk about how we got to where we are now. I'm going to talk a little bit about controversies related to masking, and I will obviously be talking about the media response, but I'm also going to talk about how we crafted our messaging from the medical community, because I can tell you, working in this arena a lot, the messaging was very confusing and changed, and the media just ran with it, and it made everybody crazy, including myself. And then included in this, we'll talk about some of the controversies related to transmission and how we look at the science and what that actually means and how it's translated, where if you are in the field, sometimes the interpretation of the science is obvious, but to the lay public, and my mom is always my thermometer because when I hear things from her, she's like, I just saw this on the news. And I'm like, yeah, Mom, it's interesting, but it was 5 people. Like that context doesn't always come across when it goes into the media arena. So I think those are the things that I'm going to talk about today. Oh, no, it's doing it again. If you want to just advance my slides, that's fine too. Well, while they're loading my slides, I'll just start with how this all began in my arena. So a little personal perspective. So end of December, I was having lunch with a colleague, and we were talking about travel plans, and we both like to travel abroad a lot. And so we were talking about, where we might go in the following year, and we both subscribed to a blog that lists cases of emerging infections and interesting sort of things that are going around the world. And she joked to me, she said, well, I wouldn't plan on going to Wuhan, China this year. And I remember looking at her, I'm like, oh, I haven't. I'm like, what are you talking about? And she said, hadn't you read your blog? I said, no, not yet. And so I immediately went and read my blog. And the blog talked about an outbreak that was of an unknown cause of severe pneumonia that was occurring in Wuhan, China, and was associated with a market where there were animals, live animals, as well as different kinds of products. And there was talk about maybe seafood being a component of this. And it, struck me as interesting, but not anything specifically that stayed in my head other than my colleagues saying maybe I shouldn't travel there right now. Fast forward maybe a week later into early January, the CDC sends out an alert and says they now have more information about this outbreak, and they have identified a novel coronavirus as the cause of this. That's when my alarm went off. And for those that are not familiar with pandemic planning, this is part of my job in infection prevention, is to think about this all the time. And I've been in my position since 2000, so I had the fortune of having been involved with the original Sars. And for those that don't know what SARS is, the original SARS, severe acute respiratory syndrome, was a coronavirus that began in China and started as a localized outbreak, which then in Hong Kong became a major issue. It spread to Toronto, shut down the city of Toronto for a very long time. Lots of people ended up losing their lives, including healthcare workers, because transmission wasn't fully appreciated in terms of how infectious this was. This is back in 2003. We did a lot of planning at the university to try and figure out what would we do if something like this ended up in the United States, including doing, active sort of having people show up in the emergency department with travel from China to see if anybody would even think about this. And then SARS went away. Now, the beauty of, and then, since then, H1N1, we were planning for pandemic flu. So I'm really lucky to have emergency preparedness colleagues that I work with a lot. And one of them in particular, Dr. Charles Little and I, did SARS training together, did H1N together. So we have this sort of ongoing back and forth that's pretty easy. So I called him when I saw the CDC alert and I said, Charlie, this worries me. And he's like, it's not gonna be anything. This is not gonna happen. And I said, remember what happened with SARS? Remember what we found out after the part, how it all evolved? A lot of this was, the SARS had already been circulating for probably a month and a half before it hit the mainstream media, before any of the governmental bodies knew. There's 6 to 8 weeks lag time that a lot of things could have gone into place that didn't. And some of this had to do with the Chinese government's sort of suppression of information. Some of it also was just things that were unknown, and they were still trying to understand these things. But needless to say, this had so much echo of the original SARS that he and I agreed we have, as part of all this planning, we have in the background the ability to ask people if they travel. And people get asked this all the time, and it gets annoying because people are like, why are you asking me if I travel out the country? Why do you care? And most of the time we don't care, but we have in the background the ability to say, if you answer yes to any specific, and Ebola also happened in this time frame, which really cemented our travel questions that come. So we turned it on, and we said, how many people travel to China from Denver anyway that are seen in our clinics? Well, in 2 weeks, there were like 30 people. I'm like, okay, this is gonna be something we better pay attention to. If somebody traveled and has symptoms, at least we can, in the background, not make everybody crazy, so we didn't announce this. Of course, the things continue to evolve, and you can see some of the headlines here. When CDC then confirms that it actually, because there was a lot of back and forth of, oh, maybe human-to-human spread, which is obviously the element that matters when you're looking at all these things. Maybe it's self-limited, and you have to have like extreme amount of contact, which again, sort of puts it in a different arena. At the time, it was still very much geographically limited, and it was occurring only in China. And then it started spreading. We had the first case in the US of what they were calling the Chinese coronavirus, or the novel the novel coronavirus, 2019 novel coronavirus. Washington State had the first patient that was identified with this. Obviously, we know now in retrospect there were other cases that had actually probably entered the United States before that time, but had not been identified, and we didn't have a diagnostic at this time either, not readily available. So that was one of the challenges sort of starting with this, and this is a New York Times article, is the world ready for coronavirus? The answer is a resounding no, we were not ready. It quickly came to, and we thought, well, we're gonna be okay. Denver is, got an international airport, but we're not that big. As we started to see what was unraveling in the Seattle area, we really kicked into high gear knowing we were going to have it and it was going to proceed. So what happened from that time? So this, I think, is from one of the early talks I did, and Johns Hopkins put up this amazing website early on that allowed you to track worldwide where cases were. So this is February 28th of 2020. And at the time, there were only about 84,000 cases confirmed. It's sort of amazing to think about that. 2,800 deaths, and most people were recovering from this. And if you look at the heat map, it was pretty much in Asia where this was spreading very dramatically. Europe had just started to have their huge outbreaks. And if you look at the United States, you can barely see the little dots there. And that just gives you a sense of, there were like 25 or 30 cases at that time that you could see. So very few cases. Of course, again, what we were watching going on everywhere else made us worry. We weren't going to be able to build a hospital in a day like the Chinese could. And we were really desperately trying to anticipate what was going to evolve with this. A year later, this is the same time frame, February 2021, 111, 112 million cases. You can see the number of deaths obviously is escalated. The whole world by this point was severely impacted by this in many ways, not just from the cases themselves, but all the second and third order effects that we will be dealing with for years, and that we had to shut down society to try and combat this. So schools, employment, hospital procedures, everything kind of got put on hold as we tried to battle this. This is obviously what's going on today. So we continue to not actually have a lot of traction in terms that we have these ups and downs, and I feel like we're on a roller coaster ride where we seem to be okay, and then you start inching up, and then you're able to look down and think, oh God, we're gonna go really fast and scary. So the big thing at the beginning of this was masking. There was a lot of stuff that came out on masking early on and these are some of the headlines in terms of what to do and what should we do. And there was a CNN tagline just a few days ago that said, why is the world still arguing over face masks? We're 20 months in. And so I'd like to explore this a little bit because I think there was so many things that were related to this that we are sort of interesting from an ethical perspective. So masks are not a new concept. They are used frequently in the hospital setting and clinical settings in general. We know that they are used to protect the person that is wearing them from individuals that have infections that potentially are transmitted typically through droplets. What are droplets? That lovely little spittle that when you cough or you sneeze, those contain viruses typically that then or sometimes bacteria can be spread in this way too. But essentially they can either land on surfaces or they can land somewhere or in proximity to you to where then you get the infection. We see this with flu. We see these with cold viruses. Again, common, accepted. The science is very well established that this works. What came into play, though, is that, and I think I had this on the other slide, but it's kind of slow, it's kind of small, is the World Health Organization said, well, yeah, we should probably wear them if you're in the clinical setting, but guess what? Everybody should wear them in general. There was a lot of debate about this in the community. People started stockpiling masks. We saw this with H1N1 influenza, where we actually started to run out of masks in the clinical setting because everybody was taking the boxes home for their family, anticipating that this was going to be a really bad thing, which was obviously horrifying because we actually have true exposure in the hospital that we have to protect against. So the WHO puts this out, and then CDC sort of curtailed the message and say, well, you don't really need the mask. It's really for us. You only need them, maybe you need them, you're protecting others by wearing them instead. And maybe you can use cloth masks, even though the studies looking at cloth masks, a lot of that out of Asia, really didn't suggest they were that good at protecting the wearer. They protected the person from spreading it perhaps by capturing those droplets, but didn't necessarily protect the wearer. And a lot of it depended on what you were using. And so there were materials that maybe were better, that the 3-layer versus 1-layer, truthfully, how well they fit made a huge difference. But then so the early ethical issues were, do you advise a principle that will actually probably keep spread from spreading by containing it, but may also limit what supplies we have in the healthcare settings? And there was a lot of dance around this because how do you explain it? You don't want people to continue to spread, but you also don't want them ordering surgical masks or going to the medical supply stores and buying every mask and then healthcare workers not having access. And that's what happened. We all experienced shortages. We were fortunate in Colorado only because my colleague had the hindsight after 2009 H1N1 to stockpile things. So we had a warehouse for our university filled with supplies that we came close to running out, but we were never having to wear the rain ponchos or the trash bags that I had sort of makeshifted in somebody's office if we needed to do it. However, a lot of hospitals did, and you remember those headlines. Healthcare workers were in the fringe of this. They were being asked to take care of droves of patients without PPE that was considered the appropriate one, and then there was controversy over what it should be. The masks that you know are available now, we have cloth masks, surgical masks, respirators, big debates, which one do you need, which one do you not need. I think what's interesting on this infographic, so I think we can say with certainty the science supports that the masks are useful, they are appropriate, they prevent, depending on the type of mask you're using, they prevent spread and they also prevent transmission to those individuals. What I think is interesting in a lot of the mask mandates and a lot of the questions that came out were then, well, you're wearing it to protect me. You're not even protecting yourself. In the clinical environment, I'm going to take that away for a second because I think that's pretty well accepted, what the rules are in the clinical environment. And it made me start really thinking about this in terms of ethical issues. And should there be a societal expectation of benevolence? Should I wear a mask to keep you safe? Why do I care that you have cancer? I don't like wearing a mask. It's my choice. So why is it on me? And this is sort of a larger issue that we talk about probably broadly in society anyway, is just that sort of assumption that we should have benevolence and community and that we do things in those ways. And yet we have to have laws to tell us that it's improper to kill people or to steal or to do. So there's sort of almost a conflict in that we say we should do this, but then we have to actually institutionalize it in some way, either by rules or laws, to make that clear that this is not what you should, that you should not be doing this in society. And then the whole debate of like, where should you use these? Again, I think in the hospital setting, you can justify this. You have a cohort of sick patients or vulnerable patients that you are encountering all the time. Proper manner. And so many of those things, I think, again, and healthcare workers we looked at this. And again, you always have to say, I'm like, did anybody read the paper or did you read the headline in the media? And we did a lot of having to go back and forth in terms of trying to get people to say, okay, this does not make sense to me. This is illogical. The sample size is too small. Or the models, like there were so many models being published. And my favorite quote from one of my friends is, models always give interesting information, but are often not actually useful because they're usually wrong, because it's a mathematical manipulation with lots of assumptions. And one of the papers that came out from the cruise ship, the Japanese cruise ship about aerosol transmission, they had to run the model like 100 times to get it to actually look at the curve. But nobody looked at that fact until you really deep dived. It just said, oh, this showed this in this model, and turned out to not be right. And I say, even in the scientific community, the medical community, I spent a lot of time having to go through and debunk some of this because there was just so much fear, so much unknown, and so much anxiety with this. Oh, now it's not forwarding. So in that same vein, I'm going to go on to, well, we're pulling up the next slide. I think the next question that went too fast. Oh, well. This is from the CDC. This is looking again at, so this was my Fear is a Powerful Tool. This is from the World Health Organization. I should have highlighted it, but this was a study looking at survival of the COVID virus on surfaces. And, they found that on cardboard or plastic or copper, the virus could survive up to 72 hours. Now, there is a next couple of lines that you read in this from the and this is real, this is published, this is legitimate data, but then this was taken as, oh, coronaviruses can survive on surfaces 72 hours. People were changing their clothes in their garage because they were worried about bringing it home. All their Amazon boxes were staying out in the cold or getting bleached. There was this incredible video my cousin sent me with how you take your groceries out of the bag so that you don't contaminate yourself with coronavirus. And it was crazy. And again, in context, the science is right, but in vitro and in vivo don't actually work. I'm like, those conditions don't exist in real life. Like, you don't have controlled humidification and temperature except in a lab. And so I think that was the other piece we struggled with very much throughout this, is just that, yes, the initial science says this, but is that translatable to the real world? What's the real translation? Is this the beginning of understanding? Absolutely. Is it the absolute? No. And of course, shortages abounded because of it. Who could get bleach for like 6 months? Not many people. as a result of that. Oh, and it's not working again. But this, I think, were the main things I really wanted to sort of talk about in terms of, from my standpoint, the things that I was constant. This wasn't even the media. This was in our medical community. The mixed messaging, the inability to explain the science in a way that made sense to individuals, even to our colleagues that don't live in my world, and then trying to make it practical in the setting of so much chaos. I think that was probably the part that was hardest, is just everybody was stressed, scared, and I think the logical thinking that most of us have when we're in our element and when we're really at the bedside or in our labs got kind of lost because of all the other distractions. And I personally will admit, during the Ebola crisis, I had read everything, I knew everything that there was to know at the time, on CDC calls, on all sorts of calls, and I would click the TV when I saw a headline about Ebola, and I'd be like, oh, I gotta hear what they say. My husband would start laughing at me. He's like, do you really think they know something you don't know? So even I am guilty of this as well. The media can play with that thoughts a lot. So on that, I think that actually was my last slide. Yeah.
Thank you so much. I think we have time for just a couple of quick questions, perhaps one from in the room and one online. Yeah, Professor Coughlin.
That was terrific. Thank you very much. The mask thing is absolutely fascinating. One thing you didn't talk about is the evolution of science. The evolution of knowledge. Early days with the mask, there were scientifically legitimate reasons why the WHO, the CDC, the Public Health Agency of Canada said, maybe, I'm not sure if you should be wearing masks. And then, now we have this body of evidence that in vitro, clinical, observational, that suggests that masks work. But that uncertainty is leveraged by those pushing misinformation. Could you talk a little bit about your experience with that evolution of the knowledge in the context of masks?
Of course, yeah. So, I can honestly say it even involved my own evolution on this. I think when we first came up with this, I was I was definitely supportive in the clinical arena. We started doing it 24/7 if you were in masking. But if you were in the non-clinical areas, I didn't mask. And a lot of it had to do with the scientific evidence, sort of, again, this debate, like and this also was the evolution of transmission and what was the primary mode of transmission, which still gets debated pretty frequently. And so that changed over time, but there was fear. So people didn't like that you didn't wear a mask. Some of it did, and I kept, I think I had this argument in the command center one day where I actually said, I am not doing something based on fear. Show me the science and I will make a change. And, I remember thinking, oh, maybe that wasn't such a great idea. That was the medical staff president that I just had an argument with. But actually, that was part of our foundation, was I wanted really good, clear science. And everybody knew that if they were going to ask me to do something, that we better have some science to do this, or something really convincing, even if it was early science. And so that our mask, if you look at all our policies on masking, it evolved rapidly. But because there was context to it, we did a lot of communication, at least internally. A lot of people, I think, were like, okay, we understand why she's doing this or how she came about this. But in the media, you're certainly right. I think it just continued to ping pong back and forth. And a lot of the data that does suggest masks are very good, I think, got lost in the sort of blitz of everybody saying, I have my own individual right to do what I want to do, and why would you hide this beautiful face? I have heard that, which makes me laugh, but at the same time is horrifying that attitude persists. But I think that caused a lot, and that's where I think CDC goofed on a lot of it, is because there was no nuance. It was not, we understand, we knew this before, we are trying to pragmatically approach this. Medicine's never been black and white. Has that been mentioned at all in all this context? No, everything is definitive, it's only this or it's only that. And I think, oh my God, the world doesn't work that way. When they changed the vaccination, masking for vaccinated people, and they said you can live free, I had a heart attack when they did that, because I work with transplant patients. And even pre-booster recommendations, we were highly aware, even without the data, that they were unlikely to have responded fully to the vaccine and were vulnerable. And that population really probably should stay masked. people that were older, we have anecdotal evidence with other immunizations, they do not respond as well and are probably still at risk. And the mortality in those groups is high. So, but that was never mentioned. There was no new, it was buried like months later. The CDC put a little disclaimer and said, well, if you're in this, luckily our clinical people know this. But again, the CDC, I think, was trying to give a gift to people and make them get vaccinated, and that was the carrot for them to do it. It said you don't have to wear a mask anymore, but it omitted the science or the nuance of the evolving science to really address those pockets that really still needed it, because they didn't think it would, they knew, it would fuel the fire.
Malia, do we have a question from the online group to close out our first half of our conference? Okay.
Thank you.
Well, then we'll go ahead and end there. Thank you, Dr. Barron. And we're running just a touch behind, so I think we'll hold our break to 10 minutes, and we'll plan to be back at 1:55 to reconvene at 1:55. So please feel free to take a break and stretch your legs.
Oh, yeah, no, absolutely. Me too.
Recommendation now, with the evidence that we have, and it may evolve.
Let me double check on my.
That is going to work. You and I. No way.
Yeah. Oh, yeah, it is.
I'll start again.
We'll do it again. We'll do it.
He's
All
got to
we-
mind of its own.
All we can try.
Fresh batteries, I don't know what.
Technology. Thank you. currently advancing. We shall see. Is it 1:55?
Yeah, 1:55, so about 5 more minutes.
So my talk may not be 20 minutes. I may be
Our goal
12.
is actually
15, right?
So we're going to change it to 15. The 20 is intended
To be the question.
15 plus
Yeah.
5, yeah.
So I may be 12 to 15. I mean,
That'd be
we'll
great.
see. We can catch up.
Yeah. We're not far behind either. We're fine.
Yeah, thank you.
1:55, I said, because we wanted 10 minutes. Yeah, we.
Hey,
From Emergency Medicine.
how are you?
Good to see you.
Nice to see you.
Yeah.
You.
Looking forward to the talk.
Oh, mine too. How's your study going?
It's going well.
Or your many studies, but you're doing the siren study, right? The monoclonal antibody study.
Yeah, it's in active 3.
Active 3, yes.
So that's going well. We finished enrollment on AstraZeneca monoclonal.
Nice.
Lead or co-lead that paper.
Nice.
It's going to be
A monster. Cool.
250 coworkers type of deal.
Gee.
But yeah, that'll be good. We're doing an outpatient monoclonal effectively.
Yeah. Congrats.
Yeah. Have you been able to pivot back to your normal
Yeah,
work? Or
I've
how's it going? Good to see you.
I've been back to it.
See you in person. Yeah.
Been back to it mostly. But still helping a little bit when needed. Focusing on the HIV work we did before.
Yeah. Are you doing mostly
Clinical trials. Yeah, I have observational pharmacokinetic studies from my kind of like my own research area, but I do part involved in clinical trials in the ECPU, which is kind of the, Yeah. The HIV trials never stop.
Okay.
They're doing active 2, active. But I mean, yeah. Like
We'll get started again in about 1 minute.
everybody, yeah. No, my pleasure. Sure. So I should pay attention to the 15. Okay, yeah. No problem. I should be fine.
Welcome back to the second session of the Research Ethics Conference. Our next speaker is Dr. Jose Castillo-Mancilla. He is an associate professor of medicine here at the University of Colorado. He'll be talking today about recruitment of Black, Indigenous, and people of color into COVID-19 vaccine studies, the mRNA 1273 experience. Dr. Castillo-Mancilla.
Well, thank you very much for the invitation, the opportunity to talk today. This is an exciting time for me. It's the first time I've spoken to a live audience since the pandemic. And then also excited to share that my daughter is scheduled for her vaccine, next week. So 6 years old, very exciting news. So this is the radiograph. What I'll talk today is about the experience that we had in trying to promote recruitment of a representative population of patients into the COVID vaccine studies, and particularly the Moderna study that was conducted here at our campus. This is a radiograph of our country today, where you can see that 60% of people in our country are self-reported white, while about 20% are Hispanic and 12% are Black, with the rest about 5% Asian, and then small percentages of other ethnic and racial groups. But you can see also that as the time is projected to continue, this trend is going to continue to evolve to the point that by perhaps by 2016, the next 40 years, the distribution of population, will be, thank you for reminding me, will be even different. You wear a mask, you don't even know you have a mask. So anyway, that's my perspective on masks. So you would say, I've been doing HIV research for the last decade, and I will talk a little bit about my experience in that and how does that translate into the COVID experience in terms of vaccine studies. But you would expect that diseases that affect the population would represent or manifest themselves the same way, particularly for each particular disease. For example, for HIV, you would expect that the proportion of patients that get newly diagnosed with HIV will reflect that graph there. 60% of the new cases would be persons who are white, 18% are Hispanics, and about 12% Black. Well, the difference actually is not the case. You can see here in this slide from ACEView, I would like you to focus on the middle bar there, if you will, where you can see that in 2018, the percent of persons who were diagnosed with HIV, new diagnoses, were 42% were Black, about 27% were Hispanic, and then the rest were white. Totally striking difference to what you can see in terms of the demographic composition of our country. But then you say, okay, well, if this is the population that is getting new diagnoses with HIV, then the research should reflect that population, right? In clinical trials for HIV, you would expect that 42% of participants would be Black, about 30% of participants would be Hispanic or Latinx, and about 30% or 25% will be white. Well, that is actually also not the case. This is a study, an old study from 2002, where actually kind of shows the proportion of participants in clinical studies that for HIV research according to racial and ethnic distribution. You can see that to the far left, back in 2002, 44% of new cases were in white persons. They're at the top, the white portion of the bar. 18% were in Hispanics. 37% were non-Hispanic Blacks. So you can see that the distribution of cases at the time in 2002. And if you go all the way to the far right, when you look at patients who actually, participants who actually ever tried to get experimental medications, who try to participate in clinical study, you can see that the proportion is almost a double from white participants in terms of the new cases to those who actually participated in clinical studies. And for Black participants, drops from 37% to 18%. So that was a very striking finding to show that, well, as a group of researchers, HIV clinical researchers have had really tremendous challenges in enrolling the population that is most affected by the epidemic. If we look at this next slide, this is a study that we performed within the AIDS Clinical Trials Group, which is an NIH-funded network of research centers and researchers doing exactly that, clinical trials in HIV. And when we ask participants of color, and in general, but focusing on Black and Indigenous persons of color, what are the reasons, or what do they actually even know that research studies are existent, and have they ever tried to be in a study? And you can see here for African American, Black persons and Hispanics, very compared to whites in the left column, very less frequently, much less frequent that they knew about studies, that they thought about being in a study,
that they tried about to be in, try to be in a study, but more importantly, the proportion of patients who actually ever were in a clinical trial was strikingly low in Black and Hispanics compared to whites. Then the question is, well, why is this happening? And the question, multiple different studies have looked at it, but in this particular study that we looked at in the same group of participants, some of the main reasons that you could think of actually we were able to demonstrate that. Black and Hispanic persons responded, in much higher proportion, that the studies were not friendly to the race. They also mentioned that they did not understand the studies and that they did not want to be a guinea pig. And this is Blacks and Hispanics compared to whites in the far left. So these are some of the reasons why we are having problem recruiting patients to HIV clinical trials. And that's why the population of these studies sometimes do not reflect the population of the epidemic. You would think, well, those are therapeutic studies in HIV. What about vaccine studies in HIV, since vaccine has been really something we've been looking for over the last, since the beginning of the pandemic in terms of HIV. And you can see also that while we have increased participation of Black persons in clinical studies for vaccines, which is the top bar over there, it's still not reflective of the demographic of the epidemic that I showed you in the second slide. So, but enough about HIV, what about COVID? And why are we talking about, why did I give you this introduction? As I mentioned, over the last decade, I've been working in HIV, and I've led a few task force to try to increase recruitment of minorities and other underrepresented populations into clinical trials. You would expect, for example, that going back to the analogy that I mentioned for HIV, using the experience that we've accumulated over time into COVID, you would expect that, well, the radiograph that I show you in terms of the population, you would expect that the proportion of cases of COVID during the pandemic would have reflected that figure, if you will. You can see into the far left that overall, 52% of the cases, of new cases of COVID that were, at least we reported at the time that this Kaiser Family Foundation graph was developed, were in white persons. 12% in Black, and 27% in Hispanic, so a high proportion of cases in Hispanic compared to the general population. Importantly, this was also translated into a higher number of deaths for both Hispanic and Black patients compared to whites. But the interesting point is that, well, when you look at the hospitalization, risk of hospitalization from COVID and risk of death from COVID-19 disease, you can see in the dark the dark blue bars in the second and the third kind of groups of bars in the middle and to the right, you can see that the risk of getting hospitalized from COVID in Blacks in the middle is 2.8, and similar to Hispanics, almost triple compared to whites. And importantly, also the risk of death in Blacks and Hispanic communities compared to whites is 2 to 2.3 times higher compared to white. So looking at this, you would say, well, if we're going to design a study that is going to look at treatment for COVID, therapeutic interventions for COVID, or in this case, vaccines for COVID-19, we have to reflect and specifically attack the population that is mostly affected in terms of severe COVID illness. So when the COVID Prevention Network was funded by the NIH, and when our site was selected to be participating in this network, my colleague, Dr. Campbell, invited me to participate with him in using the experience that we have accumulated in terms of the HIV recruitment of underrepresented populations to try to support this into the COVID vaccine studies, in this case, the Moderna Trial. So we designed a multi-pronged approach to enrollment of Black and Indigenous and people of color to try to make this study representative of what I show you today, of the persons most at risk of death and most at risk of hospitalization from COVID. And we designed a multi-pronged approach looking to try to attack multiple fronts, if you will. Try to approach governmental offices and bodies in the community organizations, specific clinics that provide clinical care for these populations. And we try to establish a very strong media presence, which is part of what the conference is the topic of the conference today, trying to access TV, radio, newspaper, and social media, which personally is something that I had really never done before myself, but it was the most effective and appropriate way to reach the largest potential population to recruit for the studies. So in terms of the government outreach, there you go. We connected strongly with the Mexican Consulate here in Denver. We were able to participate in multiple different events with them in terms of Facebook Live, Twitter, Zoom events with the leadership of the consulate, but also through a weekly community outreach event that they have, trying to outreach the Spanish-speaking immigrant population through the Mexican consulate. We established really strong relationship that I think will continue to be fruitful, not only for COVID research, but for the health of the community in general. And I feel like this was a really strong partnership. We try to do similar with the consulates of Peru, El Salvador, and Guatemala. These are the four consulates that are in Denver that serve the broadest network of Spanish-speaking communities. And of course, all these events were held in Spanish over, as I said, Facebook Live, Twitter, radio, and also printed informational kind of documentation, if you will. In terms of community organizations, we try to reach to as many as possible. We reach to Servicios de la Raza, which is a local community organization that serves Hispanic and Latinx populations. We partnered with the CCTSI, our parent, if you will, science organization, if you will, through their community research liaisons to try to recruit patients throughout the whole state of Colorado. We also partnered with the Latino Research and Policy Center here in the university and the School of Public Health to try to pass on the message to all the community organizations that they serve. And one example is their Vuela for Health, which is a Hispanic serving community organization that promotes health for adults and children throughout the state of Colorado. And also Kids First Healthcare is another example of connections that we were able to establish through the Latino Research Policy Center. And through the medical students here at the institution, we had a couple of community events with CSTAR, which is the community of students together against healthcare racism. And with all these community organizations, we scheduled a multiple Zoom events where we were able to have the community join and ask questions about the vaccines, ask questions about COVID, and we were able to also inform about the studies that were happening here in Colorado. In terms of clinical settings, we advertised at the clinics that serve specifically minorities like STRIDE and the Denver Indian Health and Family Services. And we've had a strong presence in the media through Univision Colorado, Telemundo, written media through El Comercio de Colorado, and I mentioned Facebook Live events through the Mexican Consulate. We also try to spread the fact that we're trying to recruit, if you will, minorities through word of mouth here in campus. Also patient recruitment at the clinic level in our own clinics here at the University of Colorado Hospital, and targeted recruitment in campus, as I mentioned. And I think all those interventions worked. But what I think is most important here that I want to touch about, and I'll show you the reasons why I think these things work, is that for the first time, at least in my lifetime as a researcher, the media played a critical role monitoring in real time the recruitment of patients into a major clinical study. There are millions of clinical trials ongoing around the world and in the United States, hundreds of thousands all the time. But we don't hear about who's recruiting studies for breast cancer, or what is the number of persons who are being recruited for a study in Crohn's disease. Obviously, the importance of the pandemic led to that. But I think it's important to mention that the media, I think, played a critical role on keeping us up to date of what was happening with recruitment in the studies, particularly Moderna. You may remember this informational kind of news flash showing at the end of the last year, about a year ago, that Moderna was actually not able to enroll, or was not enrolling minorities at the pace that they wanted, and they actually slowed their vaccine trial enrollment to ensure minority representation. Modification of enrollment criteria in clinical trials happens all the time, but this is the first time we actually saw it at a national or international level, where we're trying to enroll the persons most affected with the epidemic. And they also had the same problem trying to enroll volunteers for their teenager vaccine study, although they were actually finally able to do that. But this is just a real-time monitoring of what was happening in terms of enrollment, which I don't think had happened before. They finally enrolled, the Moderna study finally enrolled as planned. 37% of participants were minorities. And this graph I have to show just because it's important to show how the striking difference in the placebo arm versus the interventional arm in terms of the reduction of the COVID incidence across all groups. The proportion of patients, as I said, who were minorities, 20% were Hispanic Latino, and about 10% were Black or African American, and with other proportions of Asian. And here in Colorado, I think through our efforts, we actually were able to do even better than the general, in terms of minorities, than the general Moderna enrollment. 48% of the enrolled participants here in Colorado were white, and 30% were Hispanic, so we were able to over-enroll a little bit of Hispanics, and about 10%, 9% were Black or African American. These were, there in the graph shows the black dots are the kind of anticipated enrollment targets that we had for the study in Colorado for people, for the minority groups. In the left, you can see that we were able to over-enroll American Indian and Alaska Natives, also Black participants, and also Hispanic participants. I think demonstrating that some of the efforts that we implemented as a research group here in Colorado paid off. And what are the lessons that we learned? And this will be the last slide that I'll have. And the unanswered questions. Well, we found that early involving key players worked, the government organizations, the community organizations, and some of the key players who serve actually these communities was critical to have the recruitment, I think, that we were able to achieve. The second is we try to use culturally and language appropriate material. All the consents, of course, were translated into Spanish, but we also developed enrollment materials in Spanish to try to reach the population that needed it the most. And we were able to get involved with the community, as I said, early on, and that led to a continuous presence of the study in the community. The community events that we had were not just to advertise the study and say, please enroll in the study. They were really mostly aimed at answering questions about COVID, about vaccines, questions that the community had about other therapies. And then at the same time, we were able to pass on the message about the fact that the studies were trying to recruit people of color. And I think that was a much more effective way of doing this rather than just advertise to these organizations. We learned that people are interested in participating, but they need to understand the study, and we need to address their concerns so that they actually can participate. And the only way to do that is to actually through talking to the community. And again, I think the real-time enrollment updates influence the recruitment. I really do believe that. And I think that the more we learn about it, we might be able to use this positively to help recruit future studies, not just for COVID, but for other non-COVID studies, where a broad representation of the population most attacked by the disease or with the highest burden of disease, if you will, whether it's HIV or COVID or others, are the ones that is important. With that, I'll stop, and I'll be happy to take any questions. Thank you.
Thank you. We'll start with a question from in the room again, if anybody has one they would like to ask. If not, I'm happy to. So I actually think it's really interesting, some of the data you present about using lay media to reach out to groups that have a distrust of research or the medical system. I think you showed data that showed both halves of that. Are there concerns about using, whether that's television news or newspapers, that people will feel coerced or pushed to be involved in a study when they already have a lack of trust in the healthcare system?
I think that's a very critical point, and during all the events that we had, that came pretty much all the time. It's a very fine line to try to promote a study of any kind, in this case of the most deadly pandemic we've had since for 100 years, and trying to gain the trust of the community, particularly when they don't really, we need somebody that they don't know, right? So when you have somebody like me, you go talk to a community that perhaps I'm new to the community, I can see how they can take it with a specific, perhaps some skepticism. I think the key point was when celebrities, like Tim was mentioning, they were taking the vaccine or participating in clinical studies and mentioning about it. And for example, there's a group of physicians who I've been involved with of color who actually participated in the studies. And then they were able to tell their patients or the community organizations that know them really well, listen, I'm part of the study, and I think this is the way to do it. I think a media message that includes persons that look like the people you're trying to recruit, but also people they trust, whether it's somebody who is their physician or somebody who is in the media or the TV or other ways of communication, I think is very important. But I agree, it's a very fine line, and it's something that we got to keep working on.
Let me see if there are questions. Okay, then Jackie, go ahead, please.
So what do you think influenced Moderna to do the right thing and pause to get more involvement?
I think I think the media played an important role, and the scrutiny that they had. I mean, this is the first time, or one of the first times, that I think that we've monitored not only recruitment but also side effects, and a real clinical trial. We've all been part of in a way, of the data safety monitoring board, if you will, because we keep hearing in real time, these cases that happen all over as a community. So I think having that, demonstrating that they, if recruitment was falling slow, that they're trying to make an effort to include everybody, I think gain a little bit of confidence in the study, allow them to be transparent, and really was able to kindle, I think, the interest of the community, particularly of the community who will benefit from the vaccine the most in participating. I would try to echo this in future studies of other diseases. Unfortunately, not all of the diseases are in the media all the time. So, we don't hear about HIV as much as we hear about COVID.
So you didn't go to them and say, we're having trouble, so slow it down?
Oh, no, and particularly me, I didn't. I think this was just overall the ongoing review, or the ongoing message that the media was happening, that led to Moderna and other, in this case, Moderna we're talking about, to say, we got to keep up with what we had originally planned. So,
super interesting and super impressed with your outreach. It's funny because I was referring, how do you engage communities? You do exactly what you did. I mean, that was really impressive, and congrats on your outcome. You didn't mention social media, unless I missed it in your slides. Can you talk at all?
Yeah,
about
we did. The most of the social media that we did was through the Mexican consulate. They have a very large following here, but through Facebook and Twitter. I personally did talk about the study, to my 2 followers. But in terms of the one that we actually focused the most on was through the Mexican consulate, and they were able to get Facebook Live events and promote this, that more than promote the study. The fine line here was promoting the study is easy if you just show, here's the study, participate if you come. It's crafting the message to say, this disease is more in our community. There's a way you can participate to find a way to prevent it. This is the way to do it. And I think that through their local way of, their local community weekly events that they have, we're able to at least get that message to a specific group population. Yeah.
Thank you, and I think that'll be our time for questions. We'll move on to our next speaker. So our next speaker is Dr. Adit Ginde, who's a professor and the vice chair for research in the Department of Emergency Medicine here at the University of Colorado. The title of his talk today is COVID-19 Therapeutics, Implementing What Works, Removing What Doesn't Work, and Dealing with Uncertainty During the Pandemic.
Thanks very much, and good afternoon, everyone. Really excited to be here with the live audience as well. Also have 2 school-age daughters getting vaccinated this weekend, so it is an exciting time. We're going to spend next 15 minutes or so talking about the clinical trials zone. So I've been fortunate to have the opportunity to be involved in COVID therapeutic trials since March of 2020, in some cases participating, in some cases leading. And there's been a unique role that I think clinical trials have had on influencing media and vice versa as well. Point this somewhere. Oh, there we go. Okay, I'm good. Very quickly, we'll be touching on hydroxychloroquine and monoclonal antibodies. To the left are NIH grants supporting work in that area, and then other grant funding that is not related to today's talk on the right. Great. So one of the unique features of the pandemic response was the coordination that happened nationally and internationally around these clinical trials, both in the vaccine realm and as we're talking about right now, in therapeutics. The WHO, the UK had the recovery trial, NIH had the active platforms and the ACT platforms, REMAP CAP, with a great focus on speed, which was very important early on because there was so much uncertainty and so much fear. and putting forth prominent agents that were of interest. I think in doing that, really achieved a remarkable amount in the last 18 months and continuing now, but also led to some of the issues that we saw in the interface between clinical trials, results, and the media. I am person good. One of these programs, which we participated in a number of activities, was Operation Warp Speed in 2020. That again just poured in unprecedented resources, scientific community mobilized around the world to reach these goals. So I'm going to start talking about a few specific trials in areas, and it's a little different than a normal scientific talk because it'll have a flavor of the media. So this was one of the early successes, and still kind of one of the only successes in the therapeutic space, which was remdesivir. So these were the results of the Act 1 trial that was NIH sponsored. Something was a little amiss starting here when the first that we learned about the results was through a press release from Gilead, the company that made and partnered in this clinical trial. You'll see the last line, we understand the trial has met its primary endpoint. You'll be hearing about this more. So this is really strange because you're used to reading this in the peer-reviewed journal before any of this. And this is in April 29th of 2020. So still very early on in the pandemic. Later that day, NIH, a little bit scrambling, put out their own press release to give more of an official result. But again, by press release, you don't have all the data, hard to really interpret. And then actually just a couple of days later, this was May 1st, the FDA issued its emergency use authorization for use of remdesivir in hospitalized patients. 3 weeks later, which seemed like a long time at that time, was actually really quick, was the original preliminary report in the New England Journal that showed a 4-day reduction in hospital length of stay for patients with remdesivir proportion recovered. So, okay, we got a little reassurance seeing some actual data instead of take my word for it from the company type of information. But I think this cadence, which repeated throughout the pandemic and still happens right now, is a little bit jolting for the clinical community and for the public as well. Some things coming out around the same time. Dr. Fauci, in all his wisdom, did criticize Moderna for doing the exact same thing that happened with the Act 1 trial, with the Moderna trial, where the company pre-released results before even NIH or before publication. So I think people a little confused. And then here's where we're going to start to see a little separation. So there's big business, this is big pharma, there's a clear mistrust. A lot of the articles then start to focus on the finance component of this, stockpiling of medications, big federal purchases, $5,000 per course, $7 billion being purchased based on preliminary results that hadn't actually even been published at that point, running out of supply. So just a lot of kind of fear and panic and just chasing around information that is still relatively incomplete, and a little bit of a fundamental mistrust for big business. And an idea, and I appreciate in the keynote talk, this idea of a miracle cure. I think, that kind of shifts us into this idea that there's drugs on the shelf, they're less than $1 per dose. One of those has got to work. And I think that really set the stage for the hydroxychloroquine story, which started here with this preprint in the Journal of Antimicrobial Agents, which was a sample of 26 patients, convenient sample that received hydroxychloroquine in the hospital versus 16 non-contemporaneous controls from a different hospital that showed maybe they had different outcomes, leading almost immediately to the former president's famous tweet here about hydroxychloroquine and azithromycin being one of the biggest game changers potentially in medicine. Then more press releases coming out about, maybe the journal is putting out that this didn't meet scientific standards that were expected, but not a full retraction, these 42 patients. This one article may have been one of the most influential articles of 2020. because of what happened here. Saw a huge spike in the purchases and use of hydroxychloroquine right around the time that this came out. Then some more studies, and this is where research, I think in the clinical research, could have a negative effect as well. There's this big rush to get out this information. So this is a Lancet study with a registry analysis looking at hydroxychloroquine that was essentially saying that there was increased mortality in hospitalized COVID patients that were receiving hydroxychloroquine. So again, like this is only a few weeks after all this is happening. But then again, a week and a half later, a retraction from the Lancet saying that this was not up to standards and that the data were flawed. And you're seeing this just play out in the media, and it's really confusing for everyone, including the scientific community, let alone the lay public, to understand what is happening here. It's not surprising that there would be some mistrust about what the heck is happening, and nobody knows who to listen to and who to trust. Here's a more rigorous study, clinical trial from the Recovery Network, again by press release though, at least this was a press release from the study team itself, basically saying that there was no benefit of hydroxychloroquine in hospitalized patients with COVID-19. This is what's happening behind the scenes, right as the Journal of Antimicrobial Agents case series was published. There was an emergency use authorization for hydroxychloroquine based on anecdotal evidence, and actually use that word in the emergency use authorization. There was still wanting to have clinical trials, but we had nothing else. People were desperate. This influenced practice, even here locally. 75% of inpatients at that time would then go on to receive hydroxychloroquine during their inpatient stay, based on some of the stuff, even though people knew that the evidence wasn't there. And then, of course, a few months later, that was retracted while clinical trials were still going on. So I promise I'll get to the clinical trials. So at the same time, we, as part of a national effort, were launching and conducting a trial of hydroxychloroquine in patients, a blinded randomized control trial called ORCID. And we went on this roller coaster over this 2.5-month period. Started enrollment in April, completed the trial in June. At first, in April, this was after the EUA, questions from legitimate, questions from clinicians, from patients, from the community. How can you randomize, this was a placebo-controlled trial, how can you withhold hydroxychloroquine from these hospitalized patients? This is not the right thing, this is unethical, you cannot do this trial. So we were fighting that battle. And that Lancet paper came out. And then it was literally, aren't you killing people by randomizing people to hydroxychloroquine? We really think the placebo, this is over a span of just a couple of weeks. And all the media frenzy that occurred out of that. And then by June, it was, yeah, we already know the answer to this question. I think we're done with this. Why are you even doing this trial in the first place? And so really a roller coaster, and I think the media and science informing the media played a big role in that. We were able to complete the trial. We published in the fall of 2020 in JAMA. Really interesting editorial accompanying it that was talking media and science, politics and science related to the hydroxychloroquine story. By then there was a couple other clinical trials that came out as well. Around this time, and a lot of discussion about how the need for speed in these clinical trials were really detrimental in some ways, positive in some ways because we're getting good results. But just the speed limits and pushing out information in journals and in the media were causing problems, rushing clinical trials in the New Yorker. And then a really nice editorial by Howard Bachner and Phil Fontana-Rosa from the JAMA main journal. I can't actually, I'm hoping to read that text, but I can't see it. But essentially just commenting on how communication of these study results, making sure we do it properly. We got to get information out fast, but whether it's in the scientific journals or in the media, that it's really important to get this right also. Same time, and this was a couple months before that editorial, there was, this is a side story, one slide about ventilators and COVID, because this came out in JAMA, where basically there was national media on everybody basically put on a ventilator and COVID is dying. don't let your loved one get put on a ventilator. That was the message. And that came from this JAMA paper that came out at that time that said 88% of people that were put on ventilators in the hospital died. And then the media ran with that story and said, keep your loved one off the ventilator at all costs. When you looked a little closer, there was actually a denominator problem in that almost all the patients were still in the hospital and not included in that denominator. So patients were still alive. They went on, many of them, to still live. There's still reasonable mortality, but just that, even the journals were contributing to this. And then once it gets out in the media and the message starts replicating, it can become really problematic and actually be very harmful for public health. I'm gonna switch over. We have several more minutes left to talk about another story, which is, I think, a true success story within the COVID therapeutics realm, but also dealing with some of this misinformation media component, which is monoclonal antibodies. This was the first major monoclonal antibody trial in COVID therapeutics. This is for high-risk outpatients to prevent hospitalization. This was a trial that was conducted and sponsored by Eli Lilly, the maker of bamlanivimab, which early on, modest-sized phase 2 trial results showing 80%, 70 to 80% reduction in hospitalization. Still early, low numbers, but we didn't have anything. And this was a blinded randomized trial. So a lot of enthusiasm there. Leading a couple weeks later, this was a nice sequence because the New England Journal paper came out before major press releases. And then the emergency use authorization to use this in high-risk outpatients came out. I think very reasonable at that time. Regeneron's trial results of their monoclonal antibody agent first came out by press release, then a couple months later in the New England Journal, also showing a large reduction in hospitalization and complications from COVID, leading to their monoclonal antibody emergency use authorization. But then this became a little bit of a different problem and propagated in the media. This is an intravenous infusion, so it's logistically challenging to administer. I think there was also some mistrust by now. We're in sort of the winter of 2020, or sorry, in this fall of 2020 going into the winter, that, we don't know that the scientific community knows what they're doing. If we used with the drug supply of monoclonal antibodies, if everyone that was eligible would access it, Colorado, we would run out in 2.5 days. That didn't happen because nobody was rushing to get this treatment for a number of reasons, but I think part of it was these mistrusts and misinformation issues. And so, here's national headlines about this potentially, and we were in a bad phase of the pandemic, this is now January of 2021, that we have all this medication, potentially life-saving, just sitting on the shelf. First time resources are exceeding demand is the tagline there. Life-saving antibody plentiful, still just sitting on the shelf. Not helped by a roller coaster, and I don't blame the scientific community for this one. There's a little bit of mismessaging sometimes. In the spring of 2021, bamlanivimab authorization was revoked. This got played out in the media with the headlines, and then everybody's like, yeah, this doesn't work. We knew this wasn't going to work. Same story we saw with hydroxychloroquine, authorized, revoked. But if you look closely, it actually says, oh yeah, but the combination product still works and the Regeneron product still works. We still highly encourage this. But nobody reads the fine print. The headline was misleading. The media was misleading thereafter as well. But then even the combination product got held because of resistance from variants. This is now the beta and the gamma variant for good reasons. People don't know what to believe because all they see is that these things are authorized, then they're not, and then they just kind of stop listening. Nobody even really paid attention, in my opinion, to this New England Journal article, which was the phase 3 trial results. Really strong evidence for reduction in hospitalization and death from the agent. Then it got restarted because Delta variant happens to be sensitive to this BAM-Eddie agent in September. Some more information, but if your variants are a certain type, then you may not be able to use it. It's impossible, I think, to follow this information. Almost done. Florida, you've seen this is some politicization. Did some really good work with Governor DeSantis and mass administration of monoclonal antibodies, keeping hospitalizations down. We've now struggled with access in Colorado. The demand is finally there. The word is out to actually have the ability to administer this, and now getting on the governor's radar. Now there's mobile buses that are being placed in hotspots throughout the state to deliver this, and using the media really to get the good word out about the treatments that are available. So I'll summarize that these high pressure, unrealistic timelines for everyone, including journals and the media, can be great and can contribute to these problems as well. Creates public mistrust, and that the media then can exacerbate misinformation that they're trying to do in good faith with what's coming out in the literature, but not always clear, or be part of the solution by getting the word out about treatments that are underutilized. I'll stop there. Thank you.
And we'll start with a question from in the room. Right, sounds good. Thanks, Dr. Kors, and thank you. Our final speaker this afternoon is Dr. Thomas Campbell. Dr. Campbell is a professor of medicine and infectious disease here at the CU Anschutz campus. And his talk this afternoon is COVID vaccine trials, the impact of emergency use authorization on blinded placebo-controlled trials. Dr. Campbell.
Great, thank you very much. So for those of you who are joined by Zoom, I'm the person who's been living in the social media cave. In full disclosure, I'm a baby boomer who doesn't use social media. I've never been on Twitter, Facebook, or Instagram. So anyway, I do read the newspaper occasionally. So I wanted to start just with this headline from back in August 2020, actually July 2020, about the start of the Moderna trial. And I wanted to begin with this because what I want to talk about is how the coverage in the media did influence the trial, particularly when the trial came to its main finding around safety and efficacy of the vaccine. So this article here just announced the start of the trial. And just to tell you a little bit more about the trial, I know Jose already introduced it, but for this discussion, the important points are that the purpose of the trial was to demonstrate the safety and efficacy of the experimental vaccine called mRNA-1273. And it was designed as a phase 3, meaning large, randomized, placebo-controlled trial. So people who volunteered for the trial randomized to assigned to receive either the active vaccine or a placebo that would have no benefit. It was double-blinded, so the participants as well as the investigators and the study staff did not know who received what. And there was oversight by an independent body. In this case, it was the Data Safety Monitoring Board of the National Institute of Allergy and Infectious Diseases. The population that was specifically recruited for this trial, Jose talked about the efforts to recruit a diverse population, but the people who were recruited, in addition to being diverse, were also people who were at high risk for COVID-19, either because of their occupation, their living circumstances, their age, or their underlying health conditions. The planned duration was 25 months. And enrollment began July 27th and went very quickly, and certainly the media influenced that, and the efforts around recruitment that Jose described influenced that, such that across the 90 sites in the United States, over 30,000 participants were recruited between July 27th and October 23rd when recruitment closed. Map at the top corner just shows the distribution across the U.S. So let's then jump literally just 3 weeks after October 23rd to the next breaking headline, which is, as Adit mentioned, a press release from Moderna that their trial showed that the vaccine is 94.5% effective. Actually, in the headline's a little bit misleading in the technical sense because in clinical trials we talk about efficacy, whereas effectiveness is what's measured in the community. But nevertheless, the vaccine was very efficacious. So now we're faced with a situation where we still have people who are blinded. They didn't know what they received, whether they got a vaccine or placebo, and they're being told that those that got vaccine have 94.5% protection against COVID. So the question that arises is, what do we do? So I pose this question to you, and so it's multiple choice. There's no right answer. It's just whatever your answer is. What do you think should be done in this circumstance that I've just described, where there's high efficacy in a randomized placebo-controlled blinded trial? So should nothing be done? In other words, should we just continue on with the double-blind placebo-controlled design? Or B, that's option A. Option B, should we cross over, meaning do we take the people who got placebo and give them, or maybe not all of them, maybe part of them, give them a vaccine and take the people who got vaccine and just give them a placebo, but still maintain it in a blinded design. Option C would just be simply to unblind everybody and to offer vaccine to those people who got placebo, or some of them, maybe a subgroup of them. D would be to just unblind and say, okay, this is what you got, you're on your own, trial's over. Or E, perhaps there's something else. So let me just do a quick survey. Those of you who are joining by Zoom, you can vote online. Perhaps Marilyn or someone who's monitoring the chat can give me a synopsis. So just here in the room, raise your hand if you would favor A, do nothing. B, crossover but maintain the blinded design. So we have a number of people there. C, just unblind and offer vaccine to the placebo recipient. Okay. D, unblind but not offer vaccine. E, anything else? Any other ideas? What are people saying in the chat, Marilyn? No? Wake up, people. So what I should also say is that the protocol, despite urging from investigators from back in July or June when it was being designed, did not specifically address what was going to be done when this hopeful, we all hoped that it would come to this this finding, but yeah. So C's and B's.
Mostly C's and B's on the
C's
chat.
and B's, okay. The protocol did not actually address this. There was no plan in the protocol for what would be done. In my experience, protocols usually said that. And my experience was that, and I, like Jose, came from an HIV trials background. We found something that worked. We stopped the trial, we unblinded people, we offered the treatment to those who got the placebo. And so, number one, I was surprised that Moderna didn't do this up front. Number two, I was surprised that there was actually debate about what to do once this finding came out. And just to give you a flavor of that, and so I think this raises two questions about this. So, what is ethical to do, and also then what is feasible to do? I'm going to focus on the ethical issues for this discussion. So this is a perspective in the New England Journal of Medicine, first published online December 2nd, so not long after Moderna issued their press release. And just the excerpt here to quote is that these authors say, "We believe it is ethically appropriate to continue blinded follow-up of placebo recipients in existing trials. Trial sponsors are not ethically obligated to unblind treatment assignments for participants who desire to obtain a different investigational vaccine. So, very prominent journal. This is also not just anybody. This is the WHO ad hoc expert group. And basically what frozen. Oh, there it is. I just wasn't pressing hard enough. So basically what they were saying in this article was that the benefits of society to continuing a randomized control design and learning more about the longer term safety and efficacy of the vaccine trumped, no pun intended, everything else. So that was their argument. And then this article in JAMA, another very prominent journal, said something a little bit different. And they said that assuming vaccine scarcity, that there could be two things that could be done. First, if the result would be, or unblinding would result in major loss of valuable research data, and that there wasn't undue risk to the participants. And second, that there might be health and health equity gains because the participants in the trial would not soak up vaccine that might be given to someone else. So if those two criteria were met, then it would be reasonable to continue the blinded nature or blinded design. And so basically they said that clinical trials should offer vaccine to participants in the placebo group, but only those who would be eligible for vaccination outside of the trial. Now, one of the issues here is that 40% of the people in the Moderna trial were people at high risk of serious complications from COVID. Of the other 60%, 90% were people who were at high risk due to occupational exposure. And then finally, this is a third opinion on the other end of the spectrum. And these authors say researchers have an ethical obligation to unblind the placebo groups and offer them vaccine by unblinding and vaccinating the placebo participants, regardless of their distribution tier, meaning their COVID risk. Researchers have the opportunity to address all of the bioethical principles of beneficence, non-malfeasance, autonomy, and justice. So they're applying the Belmont principles to their argument. And they're arguing for option C in the choices that I gave you. And then finally, this was in Science. Some very prominent bioethicists authored this. And they didn't provide an outright recommendation, but what they did is to provide a framework for guiding the decision making. And so what they basically said was that after the vaccine has been safe and efficacious, it's justified to continue the blinded design only when the risk-benefit profile remains acceptable. And to determine that, they posed three questions. One, what is the social value of continuing the trial? Two, what are the risks to the participants? And three, are the risks to the participants sufficiently low and justified by the social value? So with that, I would just like to open it up for discussion and use these three questions to sort of guide the discussion. So I'm not going to tell you where I stand yet, but I'd like to know what you all think.